With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Global evacuation operations, planning medical coverage for international events, multinational companies, and humanitarian assistance. So I'll get Dr. David to start off with his presentation.
Good morning, everyone. Thank you for having me today. Tactical Emergency Medical Support, or TEMS in short, may be foreign to some of you, but it has been around for decades, and I have the privilege to be involved in both the operations and training in the last 15 years. TEMS is rapidly gaining recognition because the threats we are facing today are increasing in both diversity and severity. This has occurred in terrorist attacks in Paris twice over the last 1 year, in the Boston bombing in 2013, and recently in both Bangkok and Jakarta. I believe this sends out a very important message to all of us. We need to have specialized pre-hospital medical support in these incidents to improve survivability. I would like to discuss some important principles of TEMS and go through this series of topics. Okay, let us just look at the definition of TEMS. It is a term referring to non-military EMS that have been modified for the realities of tactical situations. And when I talk about a tactical situation or environment, in this case usually means that we have got a hostile force or entity that are present and could result in casualties or casualty. So why do we need TEMS? It is critical that we accept that conventional ambulances and EMS cannot function in certain conditions and situations. Doing the right thing at the wrong time and place can get people killed, both rescuers and casualties. Therefore, TEMS is a hybrid of special operations capability and pre-hospital emergency care. TEMS and tactical emergency casualty care training for first responders have proved valuable in numerous occasions, such as the Colorado shootings, where TEMS has to be involved to deal with an attack from a lone wolf, and also in a mass shooting incident recently in San Bernardino. These are the tactical medics in an armored ambulance, and I'll be talking about that over the next few slides. Okay, let us now watch this video.
This is the moment a French medic battles to save the life of a man in one of the
Sorry. Just give me a minute. Just want to make sure. Okay. Hopefully it works now.
This is the moment a French medic battles to save the life of a man in one of the Paris terror attacks before realizing the man he is trying to resuscitate is a suicide bomber. David, a French nurse, came across the unconscious man in the chaos of the explosion at a Paris cafe. He tried to resuscitate him using CPR. The 46-year-old had been having dinner with a friend when the explosion occurred.
Sorry, I just, there's some technical glitch, it's not streaming correctly. But anyway, just to describe the thing to you, he was actually a nurse who found a casualty after the attacks and tried to carry out CPR on a casualty. And later on, he found out that there were bolts and wires sticking out of the chest of the suicide bomber. So be very careful when you do CPR in a mass casualty incident. And he could potentially ignite the explosive device and cause a secondary explosion, and that could result in more casualties. Okay. These are some of the limitations of conventional EMS. In a tactical environment, medical providers will have to face tremendous challenges, ranging from facing hostile fire managing casualties in night vision goggles, limited medical equipment that can only be carried into the hot zone because ambulances will not be available, and varying operational requirements such as confined space and high-angle rescue in urban operations. There's also a risk of getting exposed to chemical, biological, or radiological weapons when they are utilized in a terrorist attack. Managing casualties in a mob suit, which looks like that, with the gas mask on and other PPE is very different. Psychomotor and fine motor skills will be degraded in such situations, and hence modified medical skill sets would be required to overcome such problems. Even simple bandaging can take many minutes to complete. Overcrowding in the urban setting would increase the risk of mass contamination dramatically. I've already stated some of the differences in the previous slides. It will be negligent to deploy conventional EMS when there is an unconventional emergency medical call-out. This would put them in harm's way and cause unnecessary casualties amongst the medical providers. Please take note that Homeland Security operations, military units will only be involved in specific missions. Therefore, we have to be self-reliant. I would like to emphasize that good medicine can sometimes be bad tactics, and bad tactics can lead to disasters. In a law enforcement operations, a single casualty could qualify as a mission failure. In TEMS, medical advocacy is incorporated in every phase of tactical operations. It is usually divided into pre-deployment, planning, actions during operations, and follow-up post-operations, where force protection and team health assessment of the unit is carried out to ensure that the personnel are fit for the next mission. After-action reviews are done constantly to improve doctrines, tactics, techniques, and procedures to avoid similar mistakes in the future. In the interest of time, let us just focus on the guidelines and concepts used in TEMS during operations. This is a view under the night vision goggles, and you can see how challenging it can be while managing casualties in such a situation. So the mission objectives in TEMS, are number 1, to treat the casualty, 2, to prevent more casualties, and 3, to complete the mission. Sounds simple, huh? Okay, but now we have to look at the basic concept. It revolves around the acronym THREAD from the Hartford's consensus that came out just last year. The American College of Surgeons and Federal Bureau of Investigation, FBI, jointly collaborated to bring together senior leaders from all relevant disciplines, from EMS, law enforcement, to military units, to produce a document that ultimately led to strategies to improve survival of the victims in a tactical mass casualty incident. T stands for threat suppression, H, hemorrhage control, followed by RE, which is rapid extrication to safety, A, assessment by medical providers, and finally, T, transport to definitive care or the hospital. On a more tactical level, the TEMS units around the world are adopting the Tactical Emergency Casualty Care, TECC, and Tactical Combat Casualty Care, TC3 guidelines in the management of casualties in different threat conditions. And they are divided into 3 categories of zones of care depending on the threat levels. So we have, firstly, the direct threat care, where the medical provider is in the inner perimeter and is exposed to direct threat of hostile forces like active shooters or improvised explosive devices. In indirect threat care, the medical provider is in a warm zone, or he has got some form of cover like a building, or he's away from the effects of the threat. Finally, we have the tactical evacuation care, where the medical provider is in the outermost perimeter and is a zone of safety where conveyance of patients or casualties to the hospital can occur. And this is a safe zone. So please take note, the situation can be dynamic and the different zones of care can interchange rapidly when there are multiple terrorists or improvised explosive devices. The threat is always present until it is neutralized. This is a picture of our special units from the police force doing training. For a clearer illustration, this is a picture that shows the different zones of care, with the innermost circle representing the greatest danger for both the medical provider and the casualty. It is termed as a hot zone or direct threat care. And this should be part of the planning process, and as we shall see later, in different zones of care, there will be differing management priorities. There is a paradigm shift in our management of casualties in a tactical operation. In a conventional setting, the approach of patient is airway, breathing, circulation. Whereas in the tactical medical method, we manage catastrophic bleeding first. I will substantiate later on with some statistics. And then followed by airway, breathing, and circulation. Instead of the ABC, we have the CABC. For example, in direct threat care, catastrophic bleeding has to be addressed first with a tourniquet. In addition, in a tactical operation, while giving care under hostile fire, cervical spine immobilization is not a top priority. It takes too much time. Studies have shown that it is rarely useful in isolated, penetrating neck trauma. However, in a blast or blunt injury in the neck caused by structural collapse of a building after an explosion, it is important that a medical provider takes important decisions and weigh the risk of immediate death of the rescuer against the risk of further spinal cord injury from a non-stabilized evacuation or extrication of a casualty in a highly kinetic situation. Okay. In a tactical context, the risk of death from bleeding outweighs other traumatic and medical conditions. As you can see, it contributes to about 60% of all preventable deaths, followed by 30% from respiratory conditions such as tension pneumothorax and sucking chest wound, and finally 10% from airway obstruction. So this is a video of a casualty that was shot, and this is the kind of bleeding I'm talking about. Okay. All right, this is actually a video clip from Black Hawk Down, but it is actually based on you guys thought it was real, right? Okay, this is just basically to illustrate my point that you get arterial bleeding, and this is actually based on a historical incident that occurred in Mogadishu, where the US Special Forces went in to apprehend a local warlord, but it went wrong and ended up with 18 Special Forces getting killed in that battle. So this Special Forces ranger was shot in the leg and subsequently suffered a severed femoral artery, which led to a catastrophic bleeding and finally death of this special operator. Very unfortunate, but it was shown that some of the bleeding could be stopped with the use of a simple tourniquet. Preventable deaths should be prevented. Okay. Another cause of a preventable death is tension pneumothorax. Let us have a look at the video. George Clooney. Okay, as discussed previously, this can be treated by a needle thoracocentesis. But this is a critical skill set in tactical medical training for medics and first responders, but not in most conventional EMS. Identifying injuries in preventable deaths correctly and managing them appropriately within the first 10 minutes or the platinum 10 minutes will definitely make a difference. Okay, other than the differences in injury between injury patterns between conventional TEMS, EMS and TEMS, there are distinct differences that are important in TEMS planning in urban operations. Firstly, TEMS is integrated with law enforcement units, and this would improve communications and operational effectiveness, whereas conventional EMS most of the time is dislocated, I say again, dislocated from law enforcement units in tactical operations. And this was evident in the Aurora shootings, where a lone wolf attacked a cinema, causing 82 casualties. Most casualties were managed and ferried to the hospital by law enforcement units because conventional EMS could not be deployed in a hot zone, and they were simply not trained for this. Operational security breach could also be a concern if information was leaked from the conventional EMS units attached to the law enforcement units. This occurred in the Waco incident, where the ambulance crews released mission-critical information to the press. Hostage rescue operations was compromised, and the hostage takers received invaluable intelligence unintentionally. This ended with 4 officers and 82 suspects and hostages killed. Very tragic. These are some of the missions undertaken by law enforcement units in urban operations that require TEMS support. Every mission is different, from arresting high-risk criminals to combating terrorism and riot operations. TEMS medics have to be versatile, physically robust, and highly skilled to ensure that medical support is continuous in every phase of the operations or maneuver. From my experience, dignitary protection medical support equipment can be very different from straightforward TEMS missions, since AEDs may be involved and may be deployed more readily as well, and some of the medical bags have to be inconspicuous, like a modified briefcase rather than a simple tactical trauma bag. The kind of medical care provided in these pre-hospital environments will be termed as best care in the worst places. Mission success is measured by accomplishing the objectives with no injuries or deaths resulting from TEMS. There is always a question on who we should treat first. And this depends on the policy, mission, and medical directions provided by the unit senior commanders. Some units that I'm from prioritize casualties in such a manner: hostages or injured law enforcement officers first, then followed by bystanders, and then finally perpetrators or suspects. Again, this can vary from mission to mission. Studies have shown that law enforcement officers are more willing to accept high-risk missions when TEMS is involved. The tasks of TEMS medics would include medical care in all phases of care, as I've described to you before. They have to be familiar with law enforcement operations and SOPs, especially in these areas, such as identifying weapons and devices, ability to disarm casualties safely, forensic evidence preservation at the crime scene, and to prevent disruption that could lead to legal complications later on, and handling hazardous materials, especially when biological and chemical agents are used. In anti-riot operations, I would like to emphasize, there were incidents where casualties affected by CS or tear gas were not decontaminated and were admitted to the hospitals. This led to severe problems at the ED when hospital staff were cross-contaminated. Cross-contamination is a huge issue when dealing with these chemical munitions. This could have occurred in the Little India riot if you were not prepared. And I strongly encourage that hospital staff are trained in these areas, especially when mass casualty incidents are anticipated. There's a role for conventional EMS in tactical situations. They will provide evacuation care to medical treatment facilities once TEMS has transferred the casualties to them in a cold zone. This would prevent the transportation of casualties to the hospitals that are already crowded or under-resourced in a mass casualty incident. Integration is vital. This study on the response of EMS providers to an active shooter incident pre- and post-tactical awareness training program showed that the participants were more prepared to deploy and confident in managing casualties in a tactical environment after the training. Therefore, effective training is key to gearing up conventional EMS if they were to interoperate with law enforcement agencies or TEMS. What about the lessons learned? This will include having the right equipment for the job, the use of specially designed one-handed tourniquet, hemostatic agents, and compressive elastic bandages in arresting pre-hospital hemorrhage have become game changers. There were certainly some controversies when tourniquet was initially reintroduced as a main medical device in arresting pre-hospital catastrophic bleeding in the limbs, post-911. But it's been shown in numerous studies that it is exceptionally effective in preventing hypovolemic shock in numerous studies. And if applied correctly, there will be very few complications. The public should be trained in pre-hospital hemorrhage control, just like the CPI and AED program. We have put up a public access hemorrhage control kit. This occurs in US because there are a lot of active shooter incidents. Okay. They would be force multipliers in treating casualties with hemorrhage from the extremities in a terrorist attack. This was illustrated in a Boston bombing incident where numerous casualties were saved by first responders and members of public who were trained appropriately in the control of hemorrhage or had prior military experience in casualty care. Take note that rescue and extrication, okay, in confined spaces or in urban operations are just as important as medical care. If the casualty cannot be reached or evacuated, the chances of receiving medical care will be remote as well. Okay. What about the future? Where does the future lie? There are some changes amongst conventional EMS where paramedics no longer move into only totally secured areas to manage casualties, but rather more into areas where it is safe enough to do so. This has been made possible in scene safety training by law enforcement agencies, which promotes interagency cooperation in a rescue task force. Okay. Some EMS have paramedics or medics trained with helmets and body armor so that they can operate in the warm zone or indirect threat care phase. This would definitely be valuable in a mass casualty incident that occurs in multiple sites, similar to those that you have seen in Paris attacks, where more medical providers can be deployed in semi-permissive environment. Mass casualty incident field training and exercises between stakeholders with stringent triaging system would be critical in ensuring that our plans are robust. Tabletop exercises are simply not adequate. Better preparation in the use of protective equipment in dirty bomb attack is relevant in the near future if various agents are weaponized. Hospitals and important infrastructure are also soft targets, and please take note that it is actually a focus by some of the terrorist groups. Very quickly, armored vehicles could be retrofitted as ambulances and could be a way forward in urban operations, and especially in environments such as a barricaded area. This will offer both force protection and a platform to manage the casualties while en route to medical treatment facilities, and definitely could beat the traffic as well. Okay. Train as we fight, fight as we train. Tell me what's wrong with this. Okay. The first responder has actually stuck a chest seal on the uniform of the simulated casualty. And if this was to happen in a real situation, muscle memory would kick in. And this could lead to a loss of life. So train as you fight, fight as you train. This is very important. All right. Thank you very much, everyone. Okay, I just want to say that this presentation is dedicated to those who have laid down their lives in the line of duty. Thank you.
Well, thank you, David. This really brings on a new paradigm that should we be training our EMS personnel into some aspects of tactical care as well.